Hi, everyone. We're going to start this session with a quick activity called Rate Your Understanding. So we want to get a sense of how well you understand private health insurance. So here are the options that you can choose from. They're on your screen here. The first option, 1, help. I don't get it at all. 2, I kind of get it, but still have a lot to learn. 3, so. I think I understand it well, but probably have more to learn. And then 4 is, woo, I can teach this topic. I'm basically an expert. So please take a moment and enter the number that best relates to your understanding into the chat, and we'll circle back to your responses in a moment. So hello, and welcome to Insights into Insurance, your private health coverage crash course. My name is Kelly Hughes, and I direct our health access, cost, and coverage work in NCSL's health program, and I'll be your moderator for today. So I'm so happy that you're joining us today, and we really hope that you leave this session with something valuable to take back to your state. So let's circle back to the responses that you shared in the chat. Okay, mostly 3. Okay, so most of you have some decent understanding of private health insurance, but maybe a little bit more to learn. So we hope that we have something here for you today. So why private health insurance? We know that state governments play a significant role when it comes to health insurance oversight. And it's important to understand the legislative levers that are available to you all in state legislatures to examine different coverage options and provide oversight from marketplace exchanges to employer-sponsored plans. So here's the plan for our session today. We're going to start with Samantha Scotti with NCSL, who's going to kick us off with an overview of the state roles in regulating private health insurance, followed by Haley Nicholson with NCSL as well, who will tell us all about recent federal actions that affect private health insurance. And then we'll be joined by a special guest, Joel Ario from Minot, who will really dig into those state actions and innovations and also share some insights into the new administration and what we can expect. And then, of course, we're going to have plenty of time for Q&A after each of the presentations and then at the end as well for some discussion. So before we jump in, just a couple of reminders to help you get the most out of this session, which I'm sure you've heard 25 times by now. But first and perhaps most importantly, please ask questions. It's such an important part of the learning process, and we really want to hear from you. So send us your questions in the Q&A tab. And then if you see a question that you like, you can upvote it by using the up arrow. Also, speaker bios, resources, and your poll questions, there should be 2, are located below. And then lastly, my colleague, Jack Pitzer, will be sharing our contact information throughout the session today. So you can jot down our email addresses, reach out to us after the session. We're always here for you. So before we dive in, we are going to test your knowledge on private health insurance. So along the bottom of your screen, like I said, you should see poll question number 1 and 2. Go ahead and answer poll question number 1. You can read that, select your answer. The question is, which health insurance payer covers the largest number of Americans? A, Medicaid, B, Medicare, C, employer-sponsored plans, or D, marketplace or non-group plans? What do you guys think? Take a guess, and we will get back to your answer in a moment. So with that, I am going to turn it over to Samantha Scotti, a senior policy specialist in NCSL's health program, who covers all things private insurance. And Samantha is going to give us a crash course on private health insurance and also give you the answer to the poll question. So Sam, take it away.
Hi, everyone. Kelly, thank you so much for that introduction. As she mentioned, my name is Samantha Scotti, and I'm going to just jump right in to get you that answer to your poll question. So as you'll see here, just about 50% of Americans get their health coverage through employer-sponsored coverage. So making C, employer-sponsored, the answer to that question. So that 50% combined with the 6% below on the pie chart here, which is the percentage of Americans who purchase their health insurance through marketplaces or healthcare exchanges, means that the majority of Americans have private health insurance. But what do we mean when we say private health insurance? We're going to take it back to the basics for just a moment here. So the word private is used to describe any health plan that's not administered by state or federal governments, such as Medicaid or Medicare. These plans may also be called commercial coverage or commercial insurance. And as you see on the screen here, there's a lot of terms that I'm sure you're familiar with, many of these, that accompany private health insurance. And since we don't have the time today to dive into the definition of each of these terms, we have included a link to a glossary of health insurance terms, which is available under your session resources tab. So I hope that this resource might be helpful both in today's session and as you move forward and begin to navigate this complex world that is private health insurance. So during my presentation today, I'm going to discuss the state's role in regulating private health insurance by diving into each of the legislative levers that you see here on the screen. But before we dive into each of these, it's important to first understand the state role in regulating private insurance and where states are preempted by federal regulation because of ERISA, the Employee Retirement Income Security Act of 1975. And if you're familiar with ERISA, I hope I didn't just cause you to open up your email or doze off for a moment, because yes, this is quite a lengthy and detailed piece of legislation, but it is very important in understanding the state role in regulating private health insurance. So ERISA is the federal law governing the administration of employee benefit plans. And a portion of that 50% of employer-sponsored health insurance, a portion of that falls under ERISA. And those are the 60% of employer-sponsored plans that are self-insured or self-funded, meaning the employers pay the claims for their employees as they occur. The other 40% of employer-sponsored plans are what I've termed fully insured employer-sponsored plans. And that means the employers pay a set premium to insurance company to cover the lives of their employees. So to recap here, we have the plans that states can regulate and the plans states can't regulate. So again, they can regulate those marketplace plans that I referred to in that pie chart, that 6% of covered Americans. Marketplace alternatives like short-term plans, association health plans, or healthcare sharing ministries, and those fully insured employer-sponsored plans, which are 40% of employer-sponsored coverage. So this is just important to keep in mind as you see legislation come up in your states, as you think of proposing legislation, just to understand which plans your legislation really can affect and which are then preempted by ERISA. So you will hear some more on ERISA and recent Supreme Court cases setting precedent in this area later on from my colleague, Haley Nicholson. So let's dive into those legislative levers now. So the first is surprise billing. And surprise billing is when an individual is unknowingly charged the difference in what their healthcare provider or doctor bills and what their health insurance carrier covers. And support for protecting consumers from these surprise bills is gaining support across the United States. As you'll see here, indicated in green, as of late 2020, 32 states provided consumer relief from these charges. And even though Congress was successful in passing the No Surprises Act in late 2020, states can still pass laws relating to surprise billing, like opting for different provider payment standards. And you will hear more about the No Surprises Act, this federal piece of legislation, later on from my colleague, Haley Nicholson. Next, I'm going to talk a little bit about market stabilization and reform. So going back to that pie chart and referring to those percentage of Americans who purchase their health insurance off healthcare marketplaces or exchanges. And this could be through the federally facilitated healthcare marketplace on healthcare.gov or within state-based healthcare exchanges. So many states are pursuing efforts to stabilize these healthcare marketplaces. And they're doing this by looking at the cost of these plans, so the consumer costs or out-of-pocket costs of these plans, or the availability of plans, like how many healthcare carriers are selling plans in a certain geographic area. So one way states are doing this is through 1332 innovation waivers. And these waivers allow states to waive a certain component of the Affordable Care Act in order to customize their health insurance system for their own unique state needs. In 15 of the 16 states with federally approved 1332 waivers, which is indicated here in orange, 15 of those 16 states have leveraged these waivers to create state-based reinsurance programs. And a reinsurance program aims to protect insurers from the cost of medical claims from those costly or medically complex individuals. And they do this by providing some funding to offset some or all of that healthcare claim. So essentially it's like insurance for an insurer. So you'll see also here in green, the list of states that have enacted legislation directing their respective state agencies to apply for 1332 waivers. So not yet with approved waivers, potentially with pending waivers or considering submitting waivers. It is important to note that not all of these pending waivers are looking to establish reinsurance programs. we do see some states considering other marketplace stabilization reforms, like offering a public option on their healthcare marketplace. So because we can't go into each of those pending applications or pieces of legislation, we have included a link to NCSL's 1332 webpage, which dives into each of these state examples, and that's under the Session Resource tab. Next, I'm going to discuss marketplace alternatives. So while premiums for some marketplace plans did decrease in 2020, premiums are still unaffordable for some individuals if they don't receive those Affordable Care Act subsidies that help offset some of the price, the consumer share of those healthcare plans. So because of this, some states have looked at expanding certain coverage alternatives like association health plans, short-term limited duration plans, or healthcare sharing ministries, which you see on the screen here. And these plans really intend to give states flexibility to address healthcare costs. But these plans may offer less comprehensive health coverage, as they don't necessarily have to cover or provide certain consumer protections like coverage for pre-existing conditions. So some examples we've seen of state actions directed towards these plans. We've seen some states promote the use of association health plans, short-term limited duration plans, or healthcare sharing ministries by freeing them from insurance regulations and allowing further opportunity for individuals to access these plans. But on the other hand, we've also seen some states establish consumer protection requirements around these plans, such as requiring a consumer alert to accompany the plans, notifying consumers of what this coverage includes if they're considering purchasing one of these plans. Now on to Affordable Care Act consumer protections. So since the passage of the Affordable Care Act over a decade ago in 2010, various state and some federal laws have looked at limiting or altering the federal health law. And in fact, you may be familiar with a current Supreme Court case, Texas v. California, which was heard by the Supreme Court in November. And it stemmed from a 2018 lawsuit, which sought to overturn the Affordable Care Act. I'm not going to get into a ton of detail on the Supreme Court case now, but I am going to point you to a resource being shared in the chat now by my colleague Jack Pitzer. NCSL has additional detail on this Supreme Court case as well as other related cases on one of our web pages. So I direct you to that for more information. And I wanted to point out an upcoming session at during next week's State Policy 101 series, in which our colleague will go over some of these recent Supreme Court cases, including this Affordable Care Act case. So since this lawsuit in 2018, 19 states have enacted legislation codifying consumer protections from the Affordable Care Act into their own state statute. So these consumer protections could include things like coverage of pre-existing condition, inclusion of the 10 essential health benefits, or allowing individuals to stay on their parents' health insurance till they're 26. So it is important to note that in some of these states like Arizona, Florida, and Louisiana, these consumer protection laws only go into effect if the Supreme Court overturns the Affordable Care Act. And next, on to price transparency. So the issue of high healthcare costs is something I'm sure you're all acutely aware of. If you don't have personal experience with this, I'm sure that you may have heard of issues from family, friends, or constituents. And on this topic, I'm going to actually ask you another trivia question, and I'm going to invite you to put your answers into the chat box. So the Institute of Medicine has done some research or comparison to try to put these rising healthcare costs into perspective. And they've done this by reporting what the costs of other goods would be if they had risen at the same rate as healthcare costs. So my question to you is, how much would a dozen eggs cost in modern days if the cost of eggs had risen at the same rate as healthcare services? So I'm going to invite you to put those guesses into the chat now. And for some perspective, I know this varies across the state, or whether or not you're getting farm fresh eggs, organic, or just standard eggs, but a dozen eggs cost about $2.50 or so on average. So do you think that's gone up, gone down? How much would that cost nowadays? All right, so we're seeing some guesses, $45, $15. some guesses across the board. So it's a dozen eggs would now actually cost $55 if the price of eggs has risen at the same rate of healthcare. A gallon of milk would cost $48 and a dozen oranges would cost $134. I have Kevin wins here. So Kevin, whoever put that guess in, I think was the closest. So we'll have to send you a prize later on. So I hope that comparison just provided some perspective to rising healthcare costs. And data suggests that most of this rise in healthcare costs is actually attributed directly to the cost of services like hospital services, clinical services, physician services. So because of this, state and federal policymakers are looking at leveraging price transparency as a potential tool to combat rising healthcare prices. And the intent of this is that increasing consumer knowledge of healthcare costs will create more informed consumers. So a handful of states have created all payer claims databases, which you'll see indicated here on the map. And APCDs collect healthcare claims data across payers, so from private payers to Medicaid and in some states Medicare data as well, and aggregate this data in order for states to identify costly services or high costs in particular geographic areas. And in some states, they've used this APCD data to create consumer-facing price transparency tools. And what this could look like would be, for example, a website that uses this claims data to show the real price of a non-emergent healthcare service, like a knee replacement, so that an individual can then shop for the lowest price service in their area. So it is important to note that there may be limitations with tools like this, as some consumers report some difficulty in using such healthcare shopping tools, just because of the complex nature of the healthcare system. And finally, I'm going to discuss briefly COVID-19 and private health insurance coverage. So many states are leveraging private insurance to ensure access for COVID-19 related services like testing and treatment. You'll see here indicated in green that some states have taken some sort of action to expand coverage during the pandemic. And these actions could include things like waiving out-of-pocket costs for COVID-19 testing and treatment, premium relief for individuals who might not be able to make their monthly premiums, encouraging private plans to cover telehealth or early prescription refills. And some of these actions have been done via legislation, but many are also done through division insurance rule or bulletin. And with that, I will pause there and turn it back over to Kelly to see if we have any questions or then to turn it on to my next colleague. And I do want to thank you all and remind you that while healthcare is very, very complex, this was a super high level overview. So if you need any other resources, please don't hesitate to reach out.
Yeah, thank you so much, Samantha. That was great. I hope that was helpful for everybody to just kind of lay the foundation for what the state's role is in regulating private health insurance. Try to remember that image of the 5 areas that, ingrain those in your mind and take that with you. And we are going to circle back on all of these roles with Joel's remarks later. So try to keep those fresh in your mind. I don't see any questions coming through, but if you have any at any point for Samantha or any of the other presenters, just make sure to put those in the chat or in the Q&A, and we'll be sure to get those on our end, and we'll take them throughout and at the end. So with that, I think we'll just transition into kind of the recent federal action, not necessarily the federal role, but the recent federal action related to private health insurance with NCSL's Haley Nicholson. So Haley's the Senior Policy Director of Health and Human Services in NCSL's DC office, and she's worked in federal policy and advocacy for over 7 years. You can check out her bio below, but with that, let's get into it. So Haley, floor is yours.
Thank you, Kelly. And good afternoon, everyone. I'm going to cover a few federal health insurance and related topics, including unsurprised medical billing. So I want to start with the following stats that you see and give everyone something to think about for a topic I'll touch on later in this presentation. Researchers have found that millions of Americans receive surprise bills every year, with as many as 1 in 5 ER visits resulting in a surprise charge. The average surprise charge rate can be just above $600, but some patients have received bills for larger than $100,000 from out-of-network providers. So I wanted to share these and hope people think about them once I get to the piece where I discuss federal surprise billing reform that was passed at the end of 2020 and how it could help change some of these statistics. So as Kelly said, I'm Haley Nicholson. I'm a senior policy director in our NCSL's DC office, working in health and human services policy. And here is a quick overview of some of the topics that I will be covering today, which Kelly mentioned is kind of more federal recent action related to health insurance and health insurance topics. So first, what I want to cover is what can NCSL do when federal partners make proposed changes to health insurance markets that could impact states. An example that I would like to point out is in 2017, the Trump administration had proposed a rule on selling health insurance across state lines. And they asked NCSL and some of our other state and local partners to weigh in on this, which can be very common once there's different priorities in every administration. They'll come out with proposed rules and they'll ask groups like ours, what would states think? So what we did is we sent a letter outlining a few points on these proposals. States are already allowed to sell health insurance across state lines per the McCarran-Ferguson Act of 1945. And as of 2017, 23 states had already proposed legislation to do interstate or regional health insurance sales. This can sometimes be a hard proposal to sell to states because insurers under these plans are not subject to federal or state authority. And under the ACA, insurance sales across state line, under the ACA, insurance sales are permitted across state lines, but they have to be subject to certain ACA rules, kind of around the realm Sam was talking about earlier. Things like having an essential health benefits package would be required. And association health plans, which also Sam kind of laid out earlier in the presentation, has been around since the late 1980s and would allow similar employers to form these types of plans through existing or new organizations. So on this next slide, this is a quick overview of what the actions that were taken since we sent that letter and had that initial request. What did our members think? The most recent news is that the Biden administration revoked the previous executive order expanding on AHP's association health plans and is asking federal agencies to review and consider suspending, revising, or rescinding these and other plans. I want to ask a quick chat. You can just put Y for yes, N for no in the chat. Have you been contacted by people in your state about these different kinds of plans that Sam and I have mentioned? Association health plans, limited duration. It's something that we also hear from our members that they're hearing from others in their states about enrolling or other questions they may have. Okay. And while people think about that and answer in the chat, I want to go on to another more recent action that happened at the end of last year. The Supreme Court made a significant decision when it comes to prescription drug pricing and the role of pharmacy benefit managers in their states. Now, people may be wondering, why am I bringing up prescription drug costs, pharmacy benefit managers? It seems like from the poll earlier that people here have some familiarity with private insurance or health insurance. We all can kind of understand that when we enroll in a plan, the cost of prescription drugs, what will the plan cover in relation to that, can really play a role in the plan you may pick, the plan for your family, and especially if someone is considering you need to take prescription drugs on a regular basis. So that's why I wanted to outline this recent action. So what happened in the Supreme Court case is that they decided that states may regulate the price at which pharmacy benefit managers, also known as PBMs, can reimburse pharmacies for the cost of prescription drugs. They found that this regulation was without violating ERISA, which Sam also mentioned earlier. Thank you for breaking that down. It's very complex and can be in the weeds. And it was an 8-0 decision. Now I keep mentioning PBMs. These folks are the go-between in health plans and pharmacies, and they'll do things like take actions setting reimbursement rates to pharmacies that would dispense generic drugs. And those contracts that the PBMs have with the pharmacies create a pharmacy network. Now, the case Rutledge versus the Pharmaceutical Care Management Association, the issue was whether the federal law preempted an Arkansas law that requires that PBMs reimburse these pharmacies, at no less than what they pay to acquire drugs, among other provisions. And this Arkansas law, what happened was in 2015, when it was passed, it requires that PBMs reimburse their pharmacies at one price equal to or higher than what the pharmacy paid. So we can see on this next slide, PCMA had argued that ERISA, please don't let your eyes gloss over all the times we've mentioned ERISA today. And if you have further questions, we're always happy to answer them now or after today. It was argued that it was preempted by Arkansas law, and an 8th Circuit Court agreed and concluded that the Arkansas law was making an implicit reference to ERISA. Arkansas said that this 8th Circuit Court decision had gotten it wrong, and they filed with the Supreme Court. And in their brief, they also pointed out that 36 additional states are listed as having similar laws. And I want to highlight similar because they're not all implemented the same way, but they may have some similarities in how they regulate PBM's prescription drug pricing. Now, finally, the last action that I want to talk about, and it was from the opening stats that I shared, Congress passed surprise billing legislation at the end of last year. So in the final days of the 116th congressional session, there was a bill passed containing COVID-19 relief and fiscal year 2021 government appropriations funding. It also included surprise medical billing language, the No Surprises Act. This bill was something that had been ongoing all year between different committees on a bipartisan basis for the most part, and it was looking to address surprise medical billing practices and giving new guidelines for private insurers. So 32 states already have legislation that deals with surprise billing practices. This law gives its new federal provisions that will apply to markets not controlled by the states. So what does this mean if you're a patient in surprise billing and you're in these markets? Health plans have to hold patients harmless now from a surprise medical bill, and they'll only be required to pay in-network cost sharing for out-of-network emergency care or certain services performed by an out-of-network provider. I know I'm using a lot of different terms, so if people have questions, again, please feel free to ask in the chat, or we're always happy to follow up. But a patient's in-network payment can also, for these out-of-network surprise bills, it will go towards your in-network deductible. And an example of cost sharing, some terms more of us may be familiar with as well, are co-payments, co-insurance. Again, when you're enrolling in a health insurance plan, things you may hear and wonder which one, it could determine the plan you'll pick. Another big piece of this bill was that when providers have to give the patient an estimate of the charges they're going to receive 72 hours prior to getting out of network care. And patients have to provide consent to receive that care. Now, obviously, 72 hours may not always happen for everyone. So if that appointment is made within a 72-hour window, the patient has to receive the notice the day the appointment is made, and they have to be asked for consent to receive care. Now, in an ideal world, everything would be fine. The bills would be as the patient wants to pay, would feel like it was a done deal, but that may not happen. So what the options are now is that providers and payers will have 30 days to negotiate a period to settle if there's a dispute in a claim or a cost. If they cannot reach a negotiated agreement, the parties can use now a binding arbitration process, also known as independent dispute resolution, IDR. And this is where one offer will prevail. So as we can see on this next slide, when I break down the different IDR processes, what this means is it's administered by an independent, unbiased entity that has no affiliation to the provider or the payer. And they have to consider outside data like average median network rates for services. And they also can get relevant information for what charge is being disputed by the parties involved. So following the IDR, once the decision is made, whoever initiated this process, they cannot take the same party or parties back to a resolution for that same item or service for 90 days following the decision. The last part of the bill I wanted to point out, which came as a little bit of a surprise, pun intended, is surprise air ambulance billing practices. Effectively, it's almost everything I just described to you in the process of what happens to a patient in network, out of network, but the provider in this case is an air ambulance provider. And so those patients have to be held harmless from surprise air ambulance bills. And again, only paying an in-network cost sharing for out-of-network air ambulance service. They go through the same negotiation period, but they can also account for the cost of providing these services in air ambulance, providing these services in rural or frontier areas. But the 30-day negotiation period, independent dispute resolution is all in there as well. And air ambulance providers are also going to be required to submit 2 years of cost data to the federal secretaries of Health and Human Services and Transportation and to insurers. They also will have to provide 2 years worth of claims data related to air ambulance services. And then what will happen is that these the agencies will publish a report on the costs and claims data that's submitted. And this will help establish an advisory committee on air ambulance quality and patient safety. This bill, I know I've just thrown, like Sam said, we're giving you a very high level of all these very complex issues. The bill also included things around insurance on making several changes as having in-network and out-of-network deductibles on your insurance card, implementing protections against provider discrimination, and establishing a grant program that could create new or improve existing state all-payer claims databases, which Sam gave a great breakdown of, among other measures. So with that, I want to thank everyone for your time. I'm happy to answer any of your questions, and thank you for joining us today. We know this is a lot of detail to go over in a short amount of time.
Great. Thank you so much, Haley. Again, I want to echo her remarks of please submit your questions through the Q&A and we'll be sure to get to those. And hopefully you all have a good understanding of some of the recent federal actions related to private health insurance. Okay, looking at those, not seeing anything. Okay, so with that, I think we will go right into poll question number 2. So here's our second and final poll question. You can open that on your, you can access that below the screen, the slides, and click on that, answer it now. So as I mentioned, we've heard an overview of the state's role in regulating private health insurance as well as federal actions, and we've covered a lot of topics in a short period of time. So of the topics that we've covered, which one would you really like to better understand? You may want to pick all of them, but just pick the one that's really rising to the top for you. A, ERISA, B, surprise billing, C, reinsurance section 1332 waivers, D, marketplace alternatives, E, ACA consumer protections, or F, private price transparency. Take a moment, select the topic that's really rising to the top for you. And while you do that, I am going to introduce our next special guest, Joel Ario, who is a managing director at Manat Health. He has 30 plus years of experience working in public health policy at the state and federal level. And his experience includes nearly 2 decades of which have been spent specifically on health insurance reform efforts. So he's going to tell us all about state actions and innovations related to health insurance and really give us an insight into what we may see under the new administration. Before I turn it over to Joel, I'm just going to look back and see what some of the results are of our poll question. So it looks like ERISA is rising to the top, then maybe reinsurance, followed by surprise billing and marketplace alternatives and price transparency. So really all of them, Joel, sorry, except maybe ACA consumer protections. So hopefully Joel can share some of his knowledge and experience with us on some of those topics. And then after Joel presents, we will go into some question and answer. So be sure to get your questions in for Sam, Haley, or Joel. And with that, Joel, I'll turn it over to you.
Thanks, Kelly, and thanks, Sam and Haley, for some great presentations on current issues in health regulation. Let me start with a little bit more about my background because it's, I think, helpful to you as the audience today. I was the insurance commissioner in Oregon for a while, then I was the insurance commissioner in Pennsylvania, so big state experience, small state experience, and then I worked for the federal government in setting up the Obamacare exchanges back in 2010 and 11, and then since then I've consulted mostly with the states around that set of issues. So I come at it from a state perspective. That's where I grew up in regulation. And the good news I can bring you is that as you listen to these presentations today, I'm sure your kind of mind was filled with a lot of detail, and it's kind of hard to keep track of all of it. Insurance is pretty complex. I will tell you that the state insurance commissioners, is one in every state, they all have very expert staffs as well. And so I think the starting point, if I were you on any of these issues, when you get a problem coming in that's related to insurance, or you want to write a bill on insurance, I think consulting with your insurance regulator is an important first step. They will have information on all of the issues that we're talked about today, and they can go into as much depth or keep it as high level as you want. So I spent a lot of time when I was the commissioner meeting with legislators, explaining issues, offering perspectives on different types of solutions to them. And trust me, they all like to go and talk to legislators. It's kind of a different sort of experience than sitting at their desk and working through the details of a particular policy matter, or handling a consumer complaint or whatever. So I would use that resource generously if I were you, and you can help sort out the details on many of these issues. Second thing I want to say, kind of oriented here, I was hoping to get a more specific answer as to which of these areas that you guys really cared about, but I'll kind of talk a little bit more broadly since it sounds like people are across all of them. It did sound like ERISA was first on the list, and it probably should be as a state legislator, because what you'll first hear from your insurance regulator on any issue is, I don't have a lot of authority, and you don't have authority to give me either on many of the issues that you care about, because ERISA blocks you from dealing with the large groups, most of which are self-insured. And even if they're insured, you have some authority over them, but generally they do their own thing. They're the big businesses and big insurance companies. They can each negotiate with each other. And so I think you'll find as a legislator, you're not going to often have issues with the large employer marketplace, which is about half of all of health insurance. So if you want to regulate that part of the market, you're probably going to be very limited. You're definitely going to be very limited in what you can do by the ERISA law. But the good news there is there probably aren't going to be a lot of problems. People do point out that insurance is expensive, but it's folded into your job, and so a lot of people don't even realize how expensive it is. And because it's covered well at that level, most people have policies that they like. And if you think about anybody that that's kind of planning with their kids that are getting into their 20s, like my kids are, they generally say, get a job with a big company because you'll get good insurance that way and you won't have to worry about it. That's generally true. So that part of the market we won't spend a lot of time talking about. Then the next chunk of the market is Medicaid. That's about a quarter of the market in most states these days. It's a growing part, 75 million people nationally. You will come across the Medicaid issues as a legislator. They'll primarily be because Medicaid is a growing part of a state budget, and you'll be told you can't do a lot of other things you might want to do because Medicaid continues to eat up more of the budget. There's a lot of issues in legislatures between Medicaid and education, and Medicaid and climate change, or whatever the issue is, where Medicaid is taking up a big chunk of the money because healthcare continues to get more expensive. But that's not really on point for today. That comes in more as a budget issue, I think, for a lot of you. So now we're already up to 75% of all people in those two plans. And then you got another chunk, Medicare, that's probably another 15% on average in most states, 50 million people nationally. And that is, you don't have any real authority over. That's a federal program, as you know. So, you're up in the 85%, 85 to 90, depending on the state, just those three programs. And so, when you're getting problems in the market, and most of what my three colleagues talked about today already has been mostly focused on this other chunk of people who are the individual or the small group, the really small groups that don't have the negotiating power of the large groups. That's where you're likely to hear the most about problems, and that's surprise billing or short-term plans or waivers, reinsurance waivers. All of that pertains to that chunk of the market. So I like to start with that because it's important to keep in mind who the audience is here and who's in that individual market. There are a couple of big chunks. People between jobs. It's a transitional market in many ways. A third of it changes every year. People moving between jobs go into the individual market. And the second big chunk is entrepreneurs who are out there on their own. They're not even a small group yet. They're just a single individual. They need to have individual coverage. And then people who are either unemployed and they're either too young to get Medicare or have too much income to get Medicaid, then they end up in the individual market too. So it's kind of a motley crew of people that end up in the individual market. And it's always been the weak section, the Achilles heel of our system. So the Affordable Care Act was mostly important, as you always heard President Obama say, we're only talking about the small chunk of the market, but it's the chunk that gets the most attention. And that's what we'll talk about for the rest of our time here today. So looking at that market, then I give a couple more setup points, and then I'm really anxious to hear what your questions are and get into some discussion. I'll try to be a little more provocative in this next section, maybe stir up some comments or some back and forth on a couple issues. There's always a yin yang in the health insurance world between access, people who say, I'm really want to focus on expanding coverage. We still have almost 10% uninsured in the country. I want to really get after that number of those people. And then you have the affordability people who really want to focus on making coverage more affordable. They clash back and forth. If we did this meeting 5 years ago, we would have mostly been talking about access issues. We would have been talking about the Affordable Care Act starting to move into implementation, these state exchanges, either run by the state itself or by the federal government, expanded coverage in that individual market, made it much more stable and much more affordable to people at a pretty big cost to the federal government. Federal government pays all the subsidies in those exchanges, so it's not on your state budget line. That's helpful to you. But that market now has 10 million people in it nationally. Again, that's less than 5% of the total population of the country, but it's an important 10 to 12 million that are in those marketplaces. So 5 years ago, a lot of focus on getting people covered and into those marketplaces. And we're not done with that yet. The President Biden has reopened the exchanges now for special enrollment to try to deal with a large number of uninsured people in the country, give them some choices. So access is there, but most of the issues that our colleagues talked about and that you'll focus on are going to be around affordability. How do we make insurance more affordable to people? And again, here the framing of this for you as a state legislator is that the federal government, President Biden's team, is moving forward with the proposal to make the coverage in these marketplaces even more affordable than it is today. If the bill that they currently have working its way through the House and then obviously has to work through the Senate, if that passes in March, it will substantially increase the affordability of this individual coverage. And the problem you'll most likely hear about, if you haven't heard about it already, is the way the subsidies work today. They only apply to people up to 400% of poverty, which is pretty, a reasonable number. It's like 100,000 for a family of four. And then above that level, you have to pay the full premium. So those premiums are very expensive above 400. And the proposal winding its way through the federal government now would get rid of that 400% cap on subsidies. It would subsidize everybody all the way up above 400. They would not have to pay more than 8.5% of their income. That literally applies to all the way to the richest people. But of course, at some point, people who make $1 million are not paying 8% of their income towards healthcare. So it does phase out for the wealthiest people, but it does put some people today are paying 25% of their income for individual coverage. If they're above that 400 line, they'd now get cut back to 8.5. So big gain there. And it also makes the subsidies more generous for people under 400. So there would be, if this bill passes as part of the COVID relief package, you'll get at the state level much more generous subsidies, and you'll probably get a lot of questions about how do I get into that program and how do I get myself covered. The other thing, though, that I think is even more important here is that while premiums have gone up twice as fast as inflation, that's that number. Remember, the eggs were only $2.50, now they're $55. It's because healthcare premiums have been growing twice as fast, or almost twice as fast as inflation for many, many years, and that compounds on us. But if you looked at another question, how much do people pay in cost sharing, deductibles, copays, co-insurance? That's been growing in the last 20 years at 4 times the rate of wages in the country. So that's even a bigger problem. And that's still a problem under the ACA, where, you know, you can get a policy that's affordable if you're down there at 150% of poverty. You pay very little and you get almost all of it subsidized, the premium payment, but the plan that you buy might have a $5,000 deductible. For a lot of people, obviously, those levels, they have some assistance in the program for that kind of coverage too. But if you get up to 250% of poverty or something, then above 250% of poverty, you pay the full deductible. And so if you have a $5,000 deductible and you only make 40 or 50,000 a year, it's not very good coverage. So that issue is not going to be addressed yet by the federal government. And you'll hear a lot more about that at the state level, what can be done to address that. Surprise billing is all about that, of course, because that's the sharpest edge of this, which is you buy insurance, you say, okay, I'm going to stay in network, and in network, I get a pretty good price. I don't have high cost sharing. I might have lower amounts of copays and so forth. It's when I go out of network and access a doctor that the insurer does not have a discounted rate with, that's when I pay these huge bills. And that's why surprise billing took up so much time today, and why it's going to continue to take up time at the state level, because consumers simply can't afford to pay the kind of costs of an out-of-network service. And so surprise billing says if the consumer is not told that they're out of network and blah, 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 then they don't have to, the consumer's taken out of the equation, and the insurer and the provider have to sort out who's going to pay what. The consumer is protected, and they only have to pay in-network prices. That's essentially what surprise billing does. So that's a very important protection, but you'll hear a number of other issues when we get into it in questions around, you know, how do we reduce this cost sharing? What do we do about these large deductibles that people face today? One answer that was on the list today is price transparency. If we give consumers better information, then that will create competition, and those large charges for out-of-network services will start to come down because of competition. So there is an argument that says transparency is the right answer to that. Other people say, no, we've really just got to limit the amount of cost sharing that can be put into plans. And of course, look at the large employer market where insurance works best. It's heavily subsidized by the federal government, by the way. The tax breaks for large employer insurance are the biggest tax breaks that anybody gets in the market, way bigger than the ones that people get in the marketplaces. But without, in that market, you know, generally you don't have high cost sharing, you don't have these high deductibles. You have more of them than you used to, but still less than you do in the marketplaces. So you'll be wrestling a lot with the affordability issue on premium still a little bit, but more on the issue of cost sharing and reducing those large deductibles. So those are the major points I wanted to make here. I'm just looking at my list. Oh, I'll put one more issue on the table that I think is important, and then maybe this will stir up some questions too. There are two kind of basic philosophies that people have about, you know, how the marketplaces should work. One philosophy is everybody should get the same comprehensive coverage. It should be like employer-based insurance. Employers don't give one kind of coverage to some people and different coverage to other people at vastly different prices. It's a big pool, and then people generally get the same kind of coverage. In the individual market, some people think it should work that same way, so everybody should be in the market, comprehensive coverage. Other people think, no, with coverage as expensive as it is, we should allow people to buy short-term plans or association health plans or other things that are only available to people who are healthy, so you don't get pre-existing condition protections on them, and so you're still vulnerable if you end up getting sick. But they're much cheaper, and so people say that's the solution, is give healthy people those options. And the back and forth then becomes, well, if you do that, then that increases even further the price for the people who are stuck in the comprehensive coverage and can't, you know, have a pre-existing condition. Is that fair to them? And then the other side of that is, well, no, it may not be great for them, but it's not fair to the healthy people that they have to pay for the sick people. So you're back and forth on that whole argument, and people may want to ask questions about that as well. So with that, I'll stop, and I think we have time for a lot of questions if people have more comments.
Thank you so much, Joel. It's so helpful to hear your commentary from someone who's really been in the trenches. And we are already seeing a couple questions that have come through the chat. So the first one, I think, Joel, curious if you want to take this, but Haley, feel free to jump in too. What incentive, this is around surprise billing. So what incentive do providers have to ensure that their billing is accurate? Are there any penalties for providers that are associated with incorrect billing or physician practices? Providers or physician practices. Are there any penalties for any incorrect billing? Or maybe penalties for the health plan as well?
Yeah, so billing in insurance is very complicated, and in general, this is an interesting issue. Like on surprise billing, as states start to talk about how to enforce these laws, there clearly is the insurance department who's going to enforce the responsibilities of the insurance carriers. And the question comes, who's going to enforce against the providers? There isn't in most states an easy answer to that. The insurance regulators, my fellow former colleagues, really don't want the responsibility. Quick piece of learning, which you're all in politics, you probably understand this much quicker than I do, but basically people love their doctors and they hate their insurance companies. So that translates into, in the legislature, regulating the insurance companies, making sure they do the right thing. That's easy to do. Regulating the doctors and telling the doctors, they didn't bill right or they've got a cap on their prices or anything like that is very, very controversial. So there's not great enforcement, frankly, against providers in most states. The insurance companies can do some of it through their contracts, but that's an open issue under surprise billing.
Interesting.
I'll add quickly to the No Surprises Act. And Joel, if you have any further details, the legislation will permit states, again, it's different plans. So as I mentioned, but they can enforce compliance, and then absent that, secretaries of HHS, Labor and Treasury, they can play a role in enforcement. And this is the specific bill. So like Joel said, this does not cover everyone. Billing is still very complicated, but they can face certain monetary penalties if they're found in violation. And something that we've seen as we've been tracking this issue in the last few years, because it's of concern to the states, there is definitely a bigger attention to companies when they are sending these bills, and you're seeing different media groups asking people, send me your surprise bill because the provider won't send it to me or this group won't send it to me. And so I am kind of curious to see, that was a trend that picked up where people were sending them in and reporters are putting stories together. So do companies want to have that image as well? I think that has definitely been an interesting dynamic that we would not have seen covered in that way even like 10 years ago. Now, again, still a very complex system, not always straightforward, but those are just two things that come to mind for me as well on that topic.
Let me add another really important fact here, which is that the last administration, one of their last rules was requiring every hospital to fully disclose the rates that they charge, not just the charge master, which is the published price that almost nobody pays, but also the discounted rates that they for each insurance company. By insurance company, every rate that they pay to each insurance company for every service, and then each of the shoppable services, even more detail. The hospitals hate that law. They're still fighting it, but it is now the law as of January 1st. You can go on any hospital website, and there's supposed to be a web page there that gives you their exact prices for everything. And this got a whole bunch of arguments about we shouldn't have to disclose these discounted rates. It's not going to be good for competition and so forth. But that is the law today because of the complexity of billing. And it probably is going to end up being kind of popular with consumers. But you're going to hear a lot about that law because it's still pretty controversial for the hospitals to have to disclose all of this to the consumer, and many of them are still continuing to resist it at this point.
Thank you. So Joel, we know that a healthier population is key to reducing healthcare costs. So can you speak to how insurance providers are engaging in the discussions around social determinants of health?
Oh, that's a great question. That's mostly happening still, frankly, on the Medicaid side. Every state Medicaid program is under the gun to keep its costs down. And then when people get too focused on keeping costs down, you start to worry about, does that mean the way to keep costs down is to, cut the corners on quality? So people then say, we got to have all these quality initiatives, and the current quality initiative that people are most concerned with is, if you just attend to people's health needs without looking at, the fact that they don't have a good home to work from, or they don't have food security, those issues all matter tremendously to people's overall health. So you're starting to see a big movement, particularly in Medicaid, towards the social determinants of health. We should make sure that we address the housing issues and the food issues as part of addressing people's whole person health care. It's starting to bleed over in some of the states into the commercial market, but if you ask your commercial carriers how much they're doing on social determinants of health, they tend not to be doing a lot. Again, think of the big insurance companies. They mostly make their money off of the large employer world, and that's a world where people do have good housing, they do have good food security, and so those issues aren't as much. But the more you get down the income level, and especially when you get into Medicaid, it becomes a huge issue. So again, you hear about most there, but I've got a lot of work that I do these days about trying to move what's happening in Medicaid into also commercial practice, because it is important to attend to people, not just as healthcare over here and everything else over here, but integrate it better.
That's a really interesting point. Joel, we have another question for you. We're just going to keep it going. We can't get enough. So where does public option or Medicaid buy-in fit within legislative levers? Can you explain this a little bit more? This person asking this question has heard discussions about public options in their state. So can you unpack that a little bit for us?
Sure. So this is a pretty live issue in about a dozen states right now, could expand to more states, but start with the broad framing at the federal level. The Obama team wanted a public option in the ACA at the beginning. They couldn't get it politically, so it's not in there, but it is on Biden's list. It's not in his first bill, but it is on Biden's list. And that's the easiest way to explain what it means, which is he wants to basically say, the private insurers should have a crack at every person in these exchanges, but if they can't deliver an affordable product that people will buy, then we should allow people to select Medicare instead. So basically Biden's public option is Medicare for everybody who wants it in the exchanges. That's the full version. The more limited version that they might have a better chance of passing, even this probably very difficult, would be, let's take Medicare down to 60 now. Let people get into Medicare at 60 instead of 65, start reducing the age. But the full public option would be anybody in the country, Medicare is popular, let anybody that wants to buy it, and then that will cause the insurance companies to sharpen their pencils, because they'll have to compete with Medicare prices, and that will drive down prices. That's the theory of public option. Of course, in the middle of all that is how much do providers get paid, and the reason Medicare is cheaper is because Medicare pays providers less than the commercial market. The studies out there generally say Medicare pays about half of what the commercial carriers do. So, you'll have your ear talked off by people who say Medicare has it right, and the commercial carriers are paying way too much, and so the hospitals need to have their prices brought down. And other people will say Medicare pays way too little. Every hospital in my state would have to close, particularly the rural ones, if they could only get Medicare rates. So you have a big fight about whether that will actually work, because ask the question, how much of the hospital is going to get paid under the option, and you'll start the fight about that issue. At the state level, instead of it being Medicare, it would be a Medicaid buy-in. You might say, my Medicaid program is a lot cheaper than commercial insurance, so I'm going to let people buy into Medicaid. And then the insurance companies come along and say, I've got even a better way to do it, which is don't give it to Medicaid, give it to me as an insurance company, and let me have those lower provider rates for my coverage, and I'll do a public option for you. So you have all those versions, a Medicare version, a Medicaid version, and a commercial rate version. But all of it comes back to this question about how much are the providers, particularly the hospitals, getting paid under each of those plans. And we know there's no state in the country except Maryland, which has a waiver going back 20 years, that other than that, every other state, Medicaid, Medicare pays substantially less than the commercial market. And so that's where you get involved in all that when you try to talk about a public option.
Great. Thank you so much for that breakdown. Sam, yeah.
Kelly, I will also just jump in and let you know that NCSL does track both proposed and enacted legislation around public option. So as Joel mentioned, these proposals look very different in each state. So if you'd like more information at the state level of what these look like, we'd be happy to connect with some of those resources.
I got to do a quick commercial here for one of my colleagues who just got named today to be the CMS administrator, Chiquita Brooks-Lejeune, who worked very closely with on these very issues. And we just did a big report for Oregon, sort of laying out all the different public option choices that they have and the different considerations. So if you want something that gets into the detail of that and shows you kind of where public options go, Chiquita was the lead author on that report. And, you can expect maybe this is part of what the federal discussion will be next.
Great. Yeah. Thank you for mentioning that. So another question for you regarding the Biden administration, reopening healthcare.gov for a 3-month special enrollment period. So how can states make it easier for their constituents to purchase affordable healthcare off the exchanges? Can you speak to that, Joel?
Sure. That was my job, was to create the regulatory framework for all of that back in 2010. We hoped every state would set up its own exchange, because when you do it at the state level, you have control, local control over it. You get all the data. You can micro-target the way you want to, all of that. 15 states today have their own exchanges. You can look at that map too. That's the first question asked. Do I have my own state exchange? If you do, there will be people at the state exchange, just like the insurance commissioner, who, if you call them up, they'll be thrilled to talk to you all day about all the things they're trying to do to target and build insurance. And so you got a ready-made, locally controlled enterprise there. In the other 36 states, it's 15 because it's DC, 14 states in DC. 36 states are still on the national platform, healthcare.gov. All of the states are open, by the way. Once Biden said the healthcare.gov's open, then all the state exchanges said we'll be open too. So everybody's open today. But in 36 states, it's the healthcare.gov that you have to go to do it. They are better than they've been about cooperating with local forces and kind of trying to do things at the local level. A number of states, this is an idea for states that don't have yet the resources to kind of, or the interest to make their own state exchange. You can still do a branded state website that's kind of a link to the federal one, and publicize your local agent workforce and other people who can help sell people on health insurance. But there will be a lot of, the federal government's going to get back. The Trump administration cut advertising way back on healthcare.gov. The Biden administration is increasing that again. So there'll be a lot more publicity around the exchanges. And it should be, in theory anyway, hopefully, it will be easier for people in your office, if somebody's wondering how to get a hold of an exchange or they have a problem, it will be easier to do that now with these new special enrollments and so forth.
Great. So Joel, I have a question for you. If you can just speak to how you think COVID has impacted the private health insurance market and what premiums might look like in 2021. Can you share any insights into, how COVID may be impacting private insurance?
The market is pretty good now with the insurers in the individual market and the exchanges. By the way, there is a little wrinkle here, which is not everybody that's in individual insurance is in the marketplaces. That's like 10 million, 11 million people a year. Another 3 or 4 million are in the individual market, but they're outside of the exchanges. So there's a complexity to that as well. But in general, the marketplaces have had the rates level or going down since 2017. It has to do with the way President Trump cut off some particular funding stream, and the response resulted in really high premiums in 2017, like 30% increases. Since then, everything's coming back to a more normalized level. So premiums have been either even or down in most states for the last 3 years now. And that includes for this year, for 2021. And one of the reasons is COVID for last year, because basically there were two factors at play. Early on last year, some people predicted there would be a 40% increase in premiums because of all the COVID costs. But by the time it all settled out, there weren't a lot of COVID costs. The federal government paid a lot of it, and the costs weren't as much as people thought they were going to be, maybe. And then the second thing that people really didn't expect as much, some of the actuaries were saying this from the beginning, is that people are being can't go out. They're not going to go to the doctor. So utilization was way down. So you're going to hear horror stories from your providers about, because if they're selling fee for service, the volume of services was way down, and the insurance companies made out pretty well, frankly. A lot of them had a banner year in terms of their profitability and so forth. So that 2021 was a good year for insurers, not such a good year for providers if they were on a fee for service basis. But almost every insurer in the fourth quarter of last year started reporting that utilization thing was going back to more normal. And most of them project this year that, assuming we get through the vaccination and everything and past the pandemic at some point, that utilization will come back. It's called pent-up demand, that people didn't lose their need for the healthcare, but they held it back, and they'll go do more healthcare this year. So we probably are at the end of this period where we're really having reduced rates every year, and probably the exchanges are going to be more like the rest of healthcare, which is they kind of keep going up every year, as we showed before, faster than inflation. That's probably what's going to happen. But we don't, nobody knows. I mean, if you tell me what's going to happen with COVID, I can tell you what's going to happen with health insurance prices.
You heard it here first, folks. So Joel, you touched on this earlier, but I'm wondering if we just received a question through the chat about if you want to elaborate at all on any advice that you would have for legislative staff or legislators that want to engage divisions of insurance. So anything that, particularly for someone that may be new to the legislature, is there anything that you'd want to elaborate on, kind of first steps or key advice?
There'll be a way to get a hold of the insurance regulators in every state. My little secret here, I can say this now because I don't work for a governor anymore, is that in a lot of states, the governor and the lobbying team for the governor would try to keep track of all that and bottle kind of up and say, we'll handle it. And then they control all the communication. If I were you, I would try to get to the raw source as much as I could, and kind of maybe establish a relationship with the insurance commissioner or somebody over in the insurance department. A lot of legislatures do this. They have their own sources so that they can test the agencies, not just through the governor's office. So that, I think, and you'll find generally a willing audience there, certainly to give you factual information. You start asking like, well, what's the best policy? They're going to probably usually quiver a little bit and say, I'm not really, that's your job. I'm not the expert on what's the right solution, but I can tell you, like, you want to know about surprise billing and what the rates are and what the law says. I can tell you all the facts. You have to figure out the policy. So I would say come with factual questions and try to get to the people through the commissioner's office directly, or through people in the different parts of the insurance. There's a lot of different regulatory pieces to insurance regulation. Try to get factual information as much as you can that way.
Great, thank you so much. So we're going to wrap up with one more question, and it's a big one. So what are some innovative approaches that states are taking to lower healthcare costs for consumers?
Great question. So you got a number of states who are still focused on the premium issue. The two broad strategies that people are, or three broad strategies that people are using are, first, these kind of public option ideas that we talked about. Put something out there that sort of forces the insurance companies to compete against a really low priced plan to bring down the rates. That's number one, and that expect that to continue. And there's going to be some kind of big federal debate about that probably over the next few years as well. Number two would be some form of state subsidy on top of federal subsidies. There are about 6 states now that do have their own state subsidies. California, Colorado is working on it right now. We about it this morning. New Jersey, Vermont, Massachusetts, those states all have targeted state subsidies. But again, I think you'll see if the Biden team passes the COVID bill and that really makes the federal subsidies more generous, then I think you're going to see states switch to a third strategy, which is focus on that deductible and that copayment, try to bring up so people, they get premiums affordable, but that doesn't help you a lot if you have a high deductible. So sort of focus in on that. States haven't done that yet, but I think that will be the new wave if the federal government passes its thing. And I should have said there is a fourth. Maybe it shows my own biases, but that transparency issue. There are people who still say, basically we shouldn't do what large employers do, just give their folks a rich package with very little deductible. We should really give consumers a skinny plan and with high deductibles, and then have a transparent market where they go out and buy hospital services. That is the idea behind that hospital transparency bill. So, but if you believe in that whole thing, you should just definitely talk to your hospitals about whether it's workable for them to disclose all their rates, and then people actually have high deductibles and they go around and shop for their own services. You know, they go to you can have a baby, you go figure out who's got the cheapest maternity rate. You can't even find out those rates today, but that is an idea that's out there, is if we just make all that very transparent, then, you know, that's the way to bring down costs. And it is a theory that if it works, certainly would bring down costs. That's how most consumer markets work. Question is whether healthcare can work that way or not. But again, that is the idea behind this transparency law. And I do expect the more, you know, as we're talking and I'm thinking about what's coming through across the desk, that transparency, hospital transparency law is, even though it's a federal rule, it's likely to bleed into the state legislatures this year. I certainly dealt with it every year I was an insurance commissioner, that whole issue of transparency.
Thank you. Yeah. And if and when it does bleed through the state legislatures, we will be tracking that very closely. So with that, we're going to wrap up and give folks about 5 minutes to transition. But thank you so much to Samantha and Haley, and a very special thanks to Joel for joining us today, sharing all of your knowledge. This was really insightful and interesting, and we'll see, you know, the next year and more should be really interesting in this space. We will, I apologize if we did not get to your question, we will follow up directly to answer that. And just want to thank you all for joining us today, and hope that you enjoy the rest of your Estate Policy 101 series. So thank you all and have a great day.